Hi, and welcome to the show. Subscribe at kevinmd.com/podcast and get CME for this episode by clicking on a CME link in the show notes. Today, we welcome Amy Baxter. She is a clinical associate professor of emergency medicine at Augusta University, and she's the CEO of Pain Care Labs. Her Kevin MD article today is Ending the Opioid Crisis Starts with Physicians. Amy, welcome to the show.
Thank you so much for having me, and thank you for existing along with the show itself.
We'll get into the article in a little bit. First off, share your story and journey to where you are today.
Sure. Grew up in Lexington, Kentucky. Always wanted to be a doctor, always wanted to be an emergency doctor, and then did a residency in pediatrics, a child abuse fellowship, an emergency fellowship in King's Daughters, and then a clinical research fellowship at UT Southwestern. And then my husband said, no more fellowships, get a real job. So at the time I was doing a peds emergency at UT Southwestern, and then for about 15 years, did procedural sedation and peds ER in Children's Healthcare of Atlanta Scottish Rite.
So you're in the midst of a series of articles on Kevin MD exploring the opioid crisis and pain management. Before we get into all that, how did you get interested in this area?
So I think, like most of us, I wanted to address suffering. And my path has been very eclectic, as befits an ADHD pediatrician. So I started with needle pain research. Actually, I started with child abuse and PTSD research, then needle pain, then identifying burns and scald burns in children. Then I was thinking about the pain faces scale and thought it'd be hysterically funny if the last one was vomiting. And so that was my first grant, was actually making the BARF scale, the Baxter's Animated Retching Faces scale, but in part because I felt that there's oftentimes a lot more suffering from nausea than pain, and we really weren't addressing it. So all of those things together made me very attuned to issues of what was causing pain. Also, I was raised in the 90s, so I had a no pain button that Purdue Pharma gave me at one of their OxyContin lectures. I really believed that no pain was the goal. And I believed also that opioids aren't addictive if you're really in pain. And I think was also, like all of us to some extent, we're so exposed to pharma in our education and our multiple choice test approach to medicine that we also get a little suborned by pharma as the primary solution because it's very straightforward.
So I also trained in the 90s as well. And I remember those no pain buttons and pain as the fifth vital sign, things like that. So just go a little deeper. How do you think that influenced some of the issues that we're facing today regarding the opioid crisis and pain management?
Yeah. I mean, it goes way before that. I mean, it goes to Julius Caesar saying it's easier to find men to volunteer to fight and die than to suffer pain with patience. St. Augustine said, pain is the greatest of evils. And I think that when you have a medical model, you are looking for how to cure something. You're looking for how to eliminate something. The reality of pain, which we understand much better now because of functional MRIs that only became available in the very late 90s, we understand that pain is not a switch. It's not one place. It's not a sensation that you can turn off or on. Pain is actually this spasm of reaction throughout the brain that involves memory and identity and fear and options and sorting. And it can be enhanced by previous bad experiences that connect to all these things. So if you understand pain as a survival system and understand that the brain is connected and what you're feeling is a lot of what you expect to feel, that changes how you approach it. McMaster University, McGill, does a phenomenal job on all different levels of pain education. And one of the great quotes I got from there was, pain is your brain's opinion of how safe it is. Mm-hmm. So if we're looking at pain in that way, then ignoring the biopsychosocial is ridiculous, but also trying to come up with a way to turn the switch off is equally futile. The final thing that I don't think we appreciated, and certainly a lot of this is still residual from the Sacklers and Purdue Pharma, is we don't get much pain education. In med school, on average, in the US, you get about 12 hours. In Canada, you get 20. But that's not enough to learn about what we know about how pain works. So it turns out that I really believed that opioids turned off pain, and they don't. They're a reward system. They stimulate mostly dopamine. And so rather than giving opioids out of compassion because it turns off pain, what we're doing is we're activating the reward system. So you feel pain, but you don't care. And it turns out that doesn't work very well with orals because they're so slow. And after a few days, your opioid receptors involute anyway. So giving rewards is probably also not the best way for outpatient pain relief.
All right, so let's talk more about your Kevin MD article. And today's article is the first in a series. It's titled Ending the Opioid Crisis Starts with Physicians. How did this particular article come together?
Well, I was really interested in the ERAS articles that came out probably starting 5 years ago. So enhanced recovery after surgery, and was really impressed with the fact that there were lots of places that were giving opioids after surgery, either sparingly or not at all. And there was no correlation between satisfaction or pain and how many opioids people took. I have been making devices for pain for a number of years, and an orthopedic surgeon was testing them. And he had found already that the amount of opioids was really dependent for ACL reconstruction on how many pills he gave. So they were all given 50 Percocet, and people would take 25, but he's like, they're strong, they're athletes, they only took 25. So he decided to just give 30 and see what would happen. And they took 15. And so no change in pain, change in satisfaction. So those two things together made it pretty apparent to me that what was happening was opioids were one of a toolkit that carried a lot of risk, but actually didn't give any benefit for pain management. So the devices he was testing, the interesting thing was people only took 10 with that, and they didn't have coaching. And so that is a whole different thread. But the take home that I think is important is when I wrote an article about 5 years ago that got in Doximity, maybe it was 2019, about let's just have 3 to throw. So give people something in their pocket to fall back on, but otherwise let's think about what our other pain management options are post-op. Castigated. So many people were furious at the suggestion that we limit our opioids.
Really, what was some of that reaction when you wrote that article? Like you said that you were castigated. Give an example of some of that feedback.
Oh man, emergency doctors saying, you have no idea, I cannot not write a script, or I am here to make people better, and my superpower is writing for prescriptions. So this is what I do, and it makes people better. Another person said, they're not addictive if you're really in pain, which is a complete lie, but that was part of the training we got. And I think that there also were a few people, some people contacted me offline and said, look, I appreciate what you're trying to do, but my son with his wisdom teeth had really horrible pain, and he wouldn't have gotten through it without some opioids. Turns out, 2019, also a paper by Schroeder et al. Found that 6.4% of young people who get their wisdom teeth out and get opioids have opioid use disorder within a year.
Wow.
So the paper that we're talking about now, or the article that we're talking about now, it really began occurring to me that we are talking a lot, even SAMHSA, the government substance abuse and mental health area, and I'm funded by NIDA now. Even all of what we're doing is looking at established addiction, or we're looking at social factors that lead to opioid use disorder. And I crunched the numbers, and the reality is that we have about 84 million prescriptions that are given for post-injury or post-op pain. And of the people who use opioids, their first misused opioid, about 44% of them are getting it from a medicine cabinet from someone, and about 28% are getting it from a doctor that they had surgery with. And we're almost most of misused opioids, overwhelmingly, only 20% come from the street. The rest of it come from us. We are the ones who are giving it. And I've got a graphic for those of you who are following along at home that I've looked at about 100 articles, okay, so there's so many articles on how many people are still using opioids 90 days out. Started opioid naive, using them 90 days out. And It's about 6.5%. It doesn't really matter what the surgery is. So my articles coming up are going to be about the fact that there are genetic mechanisms we understand now, and there are better ways that we could be preventing opioid use disorder, not just by keeping them out of the medicine cabinet, but also by understanding who is more at risk and then giving them other options before surgery.
So just to clarify, so someone who is opioid naive and goes through some type of orthopedic surgery, just having kind of post-op opioids, whether it's whatever, 15 Percocet, 20 Percocet afterwards, that puts them at risk for opioid use disorder going forward. There's a substantial number of those who go on to become addicted to opioids. Is that correct?
Yeah. Yeah, it's crazy. I mean, we do know with those who are not opioid naive, we know what the risk factors are. So risk factors are previous opioid use, for one thing, catastrophizing. So anxiety about pain, anxiety about the meaning of pain. Female, younger are actually usually more at risk. Certainly having family history of disorders are at risk, but one are a risk factor. But one of the big things that we are not talking about is something called rapid metabolism. So I worked with a nurse in the ER and the ED who became addicted to fentanyl and opioids. And it started with one night, actually, she was on call and she said that her stomach was hurting. So I took her into another room and I was like, I think this is your gallbladder. And it was, and she got her gallbladder out, and that was her first exposure to opioids, and she became hooked. I ended up hiring her later and asked, dude, I don't understand. How could this happen? I mean, you're stealing fentanyl from children, and you were just, such an incredible nurse. And I know how much you care about children. Where is something that flipped? And she said, from the very first pill I took, you don't understand. I have always felt anxious. I don't feel comfortable in my own skin. This made me feel wonderful. I felt loved. I felt worthy. I felt accepted. I felt so great. How can you not want to feel that way? So most of us, opioids do not make feel that way, but there are a number of different factors. And one of them is probably something called cytochrome P450 2D6, which is a metabolism that is in different percentages of people based on race and background. But between 5 and 15% of people are going to feel fantastic when they get an opioid. And that is a risk factor that they may not know until they take their very first one.
And in your article, you gave us a statistic: 80% of opioid use disorder starts with pills prescribed for pain.
Yeah, only 20% of people start with street drugs or heroin. In the 60s, most people who became addicted to heroin started with heroin, about 70%. And most of them had also started with the gateway drugs, started with marijuana, or started with alcohol, or started with cocaine, or started with Quaaludes. And it's really flipped around now because it's so much harder to find alcohol if you're young. It's so much harder to steal things and have it not be noticed. But everybody has opioids sitting around in their medicine cabinet. I've had so many injuries. I've broken my neck twice. I broke my back once. I've ripped my rotator cuff. I've had a lot of injuries that have caused pain. And when I get spasms, recently my shoulder just completely was frozen up. And I asked people in my community, like, hey, does anybody have any flex rules? Anybody have just, a pill, just a day that I can get through because it was weekend? And so many people said, oh yeah, I've got some pills. And they were all opioids. One person had eight canisters of opioids. So now we're in a situation since OxyContin, since Purdue Pharma, where most of opioid use disorder starts with something that we physicians prescribed with the best of intentions.
So tell us the path forward, because like you said a couple of years ago when you wrote that article and got such negative feedback from other practicing clinicians, clearly there's a strong bias towards the status quo and what we've been doing for decades now. How do you change our minds? How do you change the minds of clinicians?
There's some really great articles that have asked just that question. What are the barriers to non-pharmacologic or to a mix of over-the-counter and sleep aids and non-pharmacologic, physical, mental, all of these other different things? What are the barriers? different studies show different things, but the first barrier is obviously education. We are not trained on how the brain works, how pain works, and we're not trained on what works for pain. When I ripped my rotator cuff and asked for the ortho to write for massage for me because muscles that are tense and stiff pull on the nerves and it causes pain, he was like, massage, does that work? Or you just want to chill? It's like massage is something that is routinely done in Canada and many places in the world. Acupuncture, all of these sorts of things we're not educated on. The thing I didn't know, Kevin, this is awful. The thing I didn't know is how money flows in this country for pain management, and really for anything. So every single monetary decision is based on what's going to get covered. And what gets covered is from Social Security guidelines for Medicare, statute 6.3, which state that Medicare is required to take care of illness and bodily deformity in seniors, and everything flows from that. So one of the other parts of the statute says that they don't pay for comfort items. They don't define what comfort items are, but there are so many things now: cryotherapy, heat. Bracing is actually not great because it stiffens you, but it gets paid for because the thought is it's stopping bodily deformity. But the reality is that things that keep you moving and things that manipulate muscles, and certainly treatments, acupuncture is now covered in most places, but all of these other things don't fall directly under bodily deformity or illness, and so they're not paid for. So because of that, and because the appropriations for Medicaid and Medicare are dictated by Congress, but the responsibility was dictated by statute. So CMS has all the responsibility, but no authority. So they can't stop things like, okay, we're spending $17 billion on blood thinners. That $17 billion could give every person with a knee replacement an $80 physical device that decreases pain. But we don't, it's kind of like money spent at the end of life or beginning in NICUs. We don't really have a good equilibration mechanism.
We're talking to Amy Baxter. She is a clinical associate professor of emergency medicine at Augusta University. She's the CEO of Pain Care Labs, and today's Kevin MD article is titled "Ending the Opioid Crisis Starts with Physicians." Amy, tell us some of your take-home messages that you want to leave with the Kevin MD audience.
Sure. So there's beautiful data. There's so much data that for most of the things we're prescribing home opioids for, they actually don't help. Wisdom teeth, for example, ibuprofen works better, study after study. The other thing I'd like people to know is that opioids in the hospital, IV, I think we're throwing the baby out with the bathwater, but actually there's a lot of data from trauma, from battlefields, from PTSD and burns, that the more morphine the first 24 hours, the less PTSD, the less chronic pain. There's a particular receptor that's been discovered that's probably the reason for that, but I'm not worried about opioids IV in the hospital for less than 7 days. But after 3 days, the opioid receptors start to involute and become tolerant, become less sensitive. So what I'd really like to see is post-op, let's give 3 to 5 pills if you feel like you can't wean yourself off of prescribing that many, but do a little education, figure out what evidence-based non-pharmacologic mechanisms of treatment are, and find resources that can provide them to your patients. And also try to advocate some for Medicaid and Medicare to pay for non-pharmacologic mechanisms. There's something called the No Pain Act. It was added in the end of 2022 to support and pay for any proven devices or really anything that was non-opioid that reduced opioid use after surgery. CMS recently announced that instead of enacting it this year, which would have been required by statute, they're going to put it off till 2025. So there's a link that the public can comment until September 11th on this, but trying to find ways to intentionally increase your knowledge of non-pharmacologic options, decrease the number of prescriptions that are sold, and tell people to throw away the pills in their medicine cabinet. We can reframe pain to just having more comfortable be the goal, not pain-free.
Amy, Thank you so much for sharing your time and insight, and thanks for coming on the show.
Thank you so much for your forum and for having me.